So good afternoon, everyone, and thank you for attending. My name is Majid. I'm one of the endocrine registrar, and today I'm going to talk about a paper that was recently published in the Lancet Diabetes and Endocrinology about maintenance of response to oral octreotide compared with injectable somatostatin receptor ligands in patients with acromegaly. Now, just a brief reminder about the Acromegaly guidelines. In 2014, the Endocrine Society Clinical Practice Guidelines have published statements about the acromegaly management, and they have stated that surgery recommended as a primary therapy in most patients and repeat surgery to be considered in a patient with residual intracellular disease following initial surgery. And medical adjunctive therapy is recommended in a patient with persistent disease following surgery. Now, there was a specific statement about an oral octreotide at that time. An oral octreotide has been recently developed and has been tested in healthy volunteers, and more testing underway to evaluate the efficacy of oral octreotide in acromegaly. Now, 7 years later, a pituitary society has recently published updated guidelines to acromegaly management, and this was published in 2021 in the Journal of Pituitary. And I have selected specifically this statement, which is related to today's presentation about the oral octreotide. So what they have stated in their recent update that the oral octreotide capsules are suitable for patients who have demonstrated complete or partial biochemical response on injectable octreotide or lanreotide. And this was based on high quality evidence, and this was labeled as a strong recommendation. Now, coming back to the paper that I'm going to present. As introduction, this is a global randomized open label active controlled 15-month trial study, and they had two phases. So they had the run-in phase for 6 months, followed by randomization and treatment phase for 9 months. And they have enrolled participants from 29 clinical sites in different countries. Now, what they have selected as inclusion criteria for the run-in phase, they have selected adult patients with a range of age between 18 to 75 years with confirmed diagnosis of acromegaly defined as documented radiological evidence of pituitary tumor and abnormal response oral glucose tolerance test or IGF-1 of more than one upper limit of normal. And all of these patients have received somatostatin analog injections for at least 6 months with a stable dose for at least 4 months. And the participants must have been biochemical responders, which is defined as IGF-1 of less than 1.3 of upper normal limit and normal integrated growth hormone of less than 2.5 over 2 hours. Now, the exclusion criteria for the run-in phase was injection of somatostatin analog at dosing interval more than 8 weeks. If they had any radiotherapy within 5 years, they were excluded as well. If they had pituitary surgery within 6 months, they were excluded. Now, this graph shows the study design. If you look at the screening part here, where my cursor is pointing, you can see that these patients with acromegaly who were receiving a baseline and injectable somatostatin receptor ligands, and then what they have done, so the baseline, they were receiving the injectable therapy. So based on the inclusion criteria, they have selected the patients for the run-in phase, okay, and that they were given an oral octreotide capsules. And what happened during the run-in phase, which lasted for 6 months, they were titrated and they're given based on the clinical and biochemical assessment of IGF-1. So the dose can range between 40, 60 to 80. And at the end of the run-in phase, okay, they were the people or the participants who achieved or labeled as biochemical responders at week 24. They were included for the randomized controlled treatment, where they were randomized to either receive an oral octreotide capsule or to receive injectable therapy. And there was a bit offer for the open label extension for 5 years. This was an optional offer the patient who showed the response to oral octreotide therapy. Now, this is another a way to look at the study design, and this time looking at specific numbers. So they started initially with 218 people were assessed for eligibility. They were people with acromegaly, and then they excluded initially 72 people because of exclusion criteria. So they ended up with 146 participants enrolled for the run-in phase. Now, out of the 146, 30 participants discontinued, and the reason for that was 14 adverse events, and 8 had a treatment failure, were subsequently entered into the combination sub-study. 1 because of the investigator request, 6 because of withdrawal by the patients, and 1 because of the protocol deviation. Now, at the end of the 6-month run-in phase, okay, there were 24 participants completed the run-in phase, but were not randomized. And this time, because 11 of them, they entered the combination sub-study, and the 13 discontinued treatment. Now, so this was the run-in phase. After the run-in phase, they ended up having 92 participants continue to randomized treatment phase. And out of the 92% participants, they have randomized them with a ratio of 3:2, and they had 37 participants assigned to the injectable somatostatin receptor ligands, and out of the 37, 2 discontinued because of withdrawn consent, and they ended up with 35 participants complete treatment. Now they have included all, obviously, 37 participants and included intention to treat analysis. Now, on the other arm, they had 55 participants assigned to the oral octreotide and 1 discontinued treatment because of adverse event. And they ended up with 54 participants completed the treatment, and they have included all 55 in the intention to treat analysis. Now, the randomization process, as I mentioned, it happened on week 24 assessment at the end of run-in phase. And the eligible participants were randomly assigned a 3:2 ratio to oral octreotide or injectable somatostatin receptor ligands. And this was a centralized stratified randomization. And masking was not possible as interventions were different routes, given by different routes. So one is oral and the other is injection. Now, this table is showing us the baseline characteristics of the start of randomized treatment phase. And as you can see, participants in the 2 groups in the randomized treatment phase were well balanced for age, sex, and acromegaly duration. Now, I have here 2 observations to note, to report. So there was a notable difference in the number of patients with IGF at least 1.3 of upper normal limit at week 27, and this is mainly in the octreotide treatment group. And there was, and this might be partially attributed to the fact that greater proportion of patients in the oral octreotide group had tumor remnants on the magnetic resonance on the MRI than the injectable treatment group. So this was an observation on the baseline characteristics of the 2 treatment arms. Now, in terms of the primary endpoint, their primary endpoint defined as they were looking to a non-inferiority assessment of proportion of participants maintaining biochemical response in a treatment phase. And the biochemical response was defined as IGF-1 of less than 1.3 of upper normal limit. And the secondary endpoint included basically 3 main areas: symptoms of acromegaly, and they have used different tools to look at it, either by doing acromegaly direct examination each visit. This was done at least once monthly. And there was an acromegaly index of severity score for symptoms. And there was assessment using the work productivity and activity impairment questionnaire. And the other area for secondary endpoint was the treatment satisfaction, and this was done by the ACRO-TSQ square questionnaire, and this was acromegaly treatment satisfaction questionnaire. And they have looked at the treatment emergent adverse events, the safety basically assessment for the assessment of adverse events. Now, the authors have made some remarks about their statistical remarks about the assessment of non-inferiority. And they have said that the assessment of non-inferiority was made by comparing the lower bound of the two-sided 95% confidence interval for difference in biochemical response. And this was for oral octreotide versus injectable somatostatin ligand therapy, injectable therapy with a predefined non-inferiority margin of minus 20 percentage points, which was selected on the basis of previous publication that reported maintenance of response to injectable therapy was observed in 80 to 90% of patients. Now, the other statistical remark that was made by the authors of this paper was like the secondary biochemical endpoints were analyzed without adjustment for multiplicity or predefined non-inferiority margins, and therefore were interpreted as exploratory. And I will show you in the next few slides that they have used this in their reports. So just for my understanding, I just went and looked into the multiplicity. So there's this paper that was published in International Journal of Epidemiology, and they have looked into like multiplicity issues in clinical trials. So multiplicity refers to the potential inflation of type 1 error, basically false positive rate as a result of multiple testing. And this situation we are testing every time of IGF-1 at multiple visits, at each visit at regular interval. So this sometimes depends on the multi-arm, if we have multi-arm interventions, and it depends on the nature of this multi-arm intervention, whether it's like confirmatory nature or exploratory nature. Then if they're looking at the confirmatory natures, the multi-arm intervention, if they are related, if they might consider the multiplicity adjustment, and it would be required. If they are not related, then it is less need to adjust multiplicity. Now, this table showing us the primary endpoints and key exploratory endpoints. And what I have done, I have dissected this table into the three different parts that I will be discussing in details in the coming few slides. So the first bit, looking at the primary endpoint here, looking at the biochemical responders and the randomized treatment phase. So basically what they have done, they have reported the maintenance of biochemical response as a primary efficacy endpoint. So that was noticed in 91% of the oral octreotide group and 100% of the injectable somatostatin receptor ligands group. And this was based on the biochemical response was defined as IGF-1 less than 1.3, as we said. So oral octreotide, based on the previous observation, oral octreotide showed similar maintenance of biochemical response to injectable therapy, and oral octreotide was non-inferior to the injectable therapy in maintaining biochemical response. So the oral octreotide met the primary non-inferiority endpoint despite more active disease in the oral octreotide group at the baseline, as I mentioned earlier in that table for the baseline characteristics for the population, because greater proportion of patient oral octreotide group have higher IGF-1 values, and they have also at that group, they have larger tumor remnant on MRI at the trial baseline. Now, because this is an intention to treat analysis, they have run landmark analysis of the biochemical response at the end of randomized control treatment. And the landmark analysis assessed the proportion of patients with IGF-1 less than 1.3 of upper normal limit at the end of randomized treatment phase based on the average of week 58 and 62 values using non-response imputation procedure that regarded any participants who discontinued the randomized treatment phase early for any reason as non-responders. And by doing this, the landmark analysis of response met the non-inferiority criterion for primary endpoint. And the last bit, what they have looked, they have reported a sensitivity analysis of the primary endpoint. And basically my understanding by running sensitivity analysis of the primary endpoint, just to look at how robust is the primary endpoint to start with. So the sensitivity analysis of the primary endpoint that evaluated the time-weighted average response throughout the randomized treatment phase and participants who entered the randomized treatment phase as responders, and they have reported the percentage maintained response during the randomized treatment phase. And this, what they have reported that an oral octreotide group, 96%, they have maintained the response, and injectable therapy, 100%. So again, the landmark analysis, sensitivity analysis of response met the non-inferiority criterion for the primary endpoint reported area. Now, this bit, they have reported the secondary endpoints here. So they have looked at population with, who maintained or reduced number of acromegaly symptoms of randomized treatment phase. So looking at that specifically, the oral octreotide group showed 75% of reduced number of acromegaly symptoms compared to 70% in the injectable therapy group. And the overall active acromegaly symptoms at the end of randomized treatment phase were similar between treatment groups. Now, this figure shows the proportion of patients with individual acromegaly symptoms. So basically, this is to complement the previous statement. We have the right side here. So the figure A showing us the acromegaly symptoms at the end of randomized treatment phase. And as you can see, they looked at the joint pain, swelling of extremities, fatigue, headache. So basically, there was no difference seen in acromegaly symptoms. Now, figure B here shows acromegaly symptoms at the end of run-in phase. Okay, there was statistically significant reduction in swelling of extremities and fatigue. That's it. There was no difference seen in other parameters. Now, looking at the secondary endpoints, and this time looking at the Acro-TSQ scale. So the Acro-TSQ domains showed significantly greater deterioration in the injectable group therapy than the oral octreotide group during the randomized treatment phase. So basically, you can see here that the purple color represents the oral octreotide, and I think this is a pink or an orange pinkish color represent the injectable therapy. So there, as you can see, they have looked at the emotional reaction, the gastrointestinal interference, the symptoms interference, the treatment convenience, and the treatment satisfaction. And you can see, injectable therapy report, like over time, there was like deterioration of their scores over time. So one of the things that they have reported as secondary endpoints is work productivity activity impairment. So they have used this, the WPAI. And basically, there was significant improvement noted with oral octreotide compared with baseline when they given, compared to the oral octreotide showed an improvement compared to the injectable therapy, and this was in work productivity, activity impairment parameters, and presentism. Now, one of the things that they have looked at and reported is the adverse events. And the incidence of treatment emergent adverse events were similar between the two groups, as you can see here in the table on the right side. This table showing us the adverse events during the randomized treatment phase for the oral octreotide compared to the injectable therapy. And then they were similar. There was one participant that an oral octreotide group did not complete the randomized because of unrelated fatal adverse events, unfortunately. And this was accidental death from combined drug poisoning with toxicology was positive for many things, including cocaine, oxycodone. So therefore, it was reported, and there was no new or unexplained safety signals were identified by doing this. Now, The strength of this study, that this was a multi-center study. It is an international enrollment trial. They have a long-term assessment over 15 months, and the endpoint were assessed using a central laboratory assays, and there was several formal assessments for validated patient-reported outcome. Now, looking at the weakness or the limitations, the limitation of the patient-reported outcome analysis is that the patient chose to participate in this trial. So the enrollment population might be enriched for people who are not happy, not satisfied with their injectable therapy to start with. So that might be considered as a weakness or limitation. The trial did not monitor actually for pituitary tumor or residual control. So there was no like an assessment for radiological assessment at any point. Although they started with having look at that at some point as a baseline, but they did not put it as one of the protocol tests to be done during the follow-up. And the trial was not powered enough to report superiority between the arms. So we are reporting here non-inferiority, but we cannot say which one is the best. And the trial did not identify the predictors of response to oral octreotide, so they could not identify which patient will be showing the best response or the best responders to oral octreotide. There was no mention of that. And the last 2 points actually was, it's not directly related to the paper itself in terms of limitation or weakness. It's about the nature of the medication itself, the bioavailability of oral octreotide, and overall, it shows a very reduced 90% of bioavailability was observed if taken with food in these medications. That's why all of these patients who were offered oral octreotide capsules, they were advised to take the tablets twice daily on empty stomach, either 1 hour before food or 2 hours after any meal with full glass of water. So the bioavailability of the medication, it's greatly variable with the food intake. And obviously there is a cost factor here. And then there is like, the reported cost is around £2,000 for a supply of 28 capsules. So that's a pretty high cost for the treatment as oral octreotide capsule. And that's it. That's my presentation. I have one complimentary slide, but I want to open the floor for any discussion or comments before I proceed.
Thank you, Majid. That was very nicely presented. We have some his hands up already.
Thank you. I'm so sorry, I missed the beginning. Majid, you may have explained this already. How does this resist digestion? So how does oral octreotide work?
So the oral octreotide, what they have done, they have the oral preparation formulated.
Do you want to unshare your screen? So
oh, sorry. Sorry, I'm lost here. I don't know how to do that.
Just a screen share at the bottom, the green.
Okay.
Great.
I don't have camera here, sorry.
Sorry,
Yeah.
I thought we can see you.
Yes, so my understanding that over the years they have formulated a capsule where there are like different layers that goes through delayed absorption process. And these layers have they have the ability to delay the response or the absorption of the medication itself. Although I don't have the specific like characteristics of what exactly these layers about, but that's how they have mentioned it. Like it's octreotide formulated in different layers where it goes a different process of absorption to delay and to maintain the bioavailability. So if you combine these layers with the food at the same time, then there will be a very reduced bioavailability.
No, it's just I've tried to understand what it is that is surrounding the peptide, and I can't get. I don't think they've disclosed that, but maybe.
Not in this paper. In the previous studies, yes, I didn't. Sorry, I didn't have that information in my hand now, but in previous studies, yes, the initial reports about the medication itself, the safety, yes, but I can't recall it from the top of my head now, sorry.
Can I ask, the non-responders that were then excluded from the study,
Yes.
how many were they, and why, what's different about that group, do you know?
Yes, so
You self-selected a group that respond.
yes, so the non-responders were like the people who are the patients with acromegaly who were given an oral octreotide and they have received the maximum dose of 80 milligrams per day. So that's 40 milligram twice daily tablets. And that they, despite that dose, they were having persistently elevated IGF level or persistent symptoms of acromegaly. Despite reaching that dose. So they were classified as non-responders. And then later on, they were offered a sub-analysis group where they have taken all of these people and they consented some of them. And the people who have given the consent, they have offered them a combination therapy of oral octreotide capsule with cabergoline. So they have offered that combination therapy for these people who did not show any response to the 80 milligram maximum dose of oral octreotide dose. I have a bonus slide about that. I was like keeping it toward after the thank you slide. Maybe I can share that just to make
Was
it.
there anything that defined that group? Did they have the higher IGF ones at the start, or what, was there anything?
No, they did not report that they did have a higher sorry, I'm trying to bring up the slide where I'm talking about this. Yes, so what they have done, basically this is like the slide that I was, they have mentioned this, not in the initial, in the original paper itself. They have mentioned it in the supplementary document attached with the study. So they have a total of 14 patients who entered the combination sub-study and 3 who terminated early due to failure to respond to the 80 milligram of oral octreotide capsule for more than 2 weeks during the 26th run-in phase, and 11 who completed the run-in phase but were eligible to enter the randomized control phase on 80 milligram owing to inadequate biochemical response. And what they have done, they have given them cabergoline in addition to the oral octreotide. And then the final cabergoline dose in the sub-study were 1 milligram and 2 milligram in 5 patients, 2 milligram in 3, and 3 milligram in 1 patient, and 3.5 in 5 patients with almost 26 weeks mean treatment duration. And around 6 of these patients, 43%, showed reduced overall number of active acromegaly symptoms at the end of the combination sub-study. And there was no serious adverse events related to the cabergoline, combination cabergoline plus oral octreotide. So they have reported on this, but to answer your question, no, they could not identify any specific predictors that why these specific population have poor response to the oral octreotide.
Was it? You wanted to ask something?
Yeah, so I was just going to make a couple of points. I mean, I think the biggest thing is that about 150 were entered and then 100 went through into the randomization. So you're basically saying a third don't respond.
Yeah.
And you're not really going to practically see them in clinic every few months, see if they respond. Yeah, so you've got the 146 down to 92. So the reality is in clinic, a third of those aren't going to respond. And we haven't got the infrastructure in place to then screen them in if they respond and all of this.
Yeah.
The other thing is it looks like the cost is obviously double what monthly is. It's affected by food massively. And I know they haven't tested for superiority, but pretty much all of the oral numbers were a bit less than the subcut. And if I was a patient, I'm not sure a monthly injection is such a bad thing for, you know, minus 20% non-inferiority. I'm sorry, I'd rather have the 0% non-inferiority. I don't know where they set the minus 20 from. They said previous publications, but the previous publications are biased as well. So I'm not saying it doesn't work. I'm just saying it might work in private practice where you could follow them up and see if they respond and if they really had a problem with the injections. But I don't think we see that many people with issues with the monthlies, which are cheaper and more effective.
I think the only side effect is that sometimes people get the diarrhea and stuff, but I agree with you.
But there was no difference in side effects between the oral and the injectable.
No.
It's still the same compound. So, you know, you might argue that the oral might give you more diarrhea. I don't know. But I mean, priced at the same, I think that the first bit is the bit that worries me is they selected those, you know, they should have just taken anybody who was on an injectable and then split them into two, which they haven't done. They've taken those who are on injectable responding, made sure they responded to the oral octreotide, which is only 2/3 of them. And then they've done the numbers and then there's not that much difference. But if they did the study again, which they might not want to do, which is to split them at the beginning and randomize them straight away, you'd get a fair response.
Yes.
Because what will happen in the clinic is we would just start, we're not going to start with subcut and then switch them over. You just start them on oral. That's what they would want us to do.
Do we know the people who didn't respond actually took the tablets?
But I don't think it matters, does it? That's what happens. So probably what happened with the non-responders is that they weren't taking it an hour before food or after food, because they said 90% reduction is pretty massive, isn't it? So
I agree.
I mean, that just tells you that in real life, that's what's going to happen. So you'll have 1/3 of people probably not responding. And then after that, the other 2/3 probably have a similar effect for double the price. Doesn't sound like a great deal. I think in a subgroup that come along and say, I don't like my monthly injections, it's a fair point, but that's not the group they're going for.
Yeah.
You might argue a monthly injection is actually easier to take and remember than a daily, an hour before or 2 hours after food.
Yeah. Thank you.
The timing with the food is not easy.
No.
It does limit your lifestyle, doesn't it?
Yeah.
Completely.
The best time to take tablets is just before you go to bed. Doesn't matter whether you're on an empty stomach or not. Or first thing in the morning, but then you have to take it, you can't have your breakfast for an hour.
One of the patients was so upset with it that they.
No. Thank you, Martin. Any other questions?
Thank you everyone for the comments and the interaction. Thank you.
It's a very good presentation. It's very clear.
Thank you, that was great.
Thank you very much. Thanks.
Thank you, Majid. Nice you're back.
Thanks, Majid.
Thank you.
Bye. Thank you.
Bye-bye.